today we're going to focus on starting the IV as well as starting the primary IV fluids. So actually in your lab book we're going to combine two of the skills together. And so this is what you'll need to be prepared to do while that you are in the lab for your checkoff day. So again, we're looking at IV insertion angiocath as well as starting the primary intravenous infusion. So the materials that we're going to need to go ahead and start out are going to be some primary tubing. And so again, it must say that it's primary. We're going to need the prescribed fluids. So again, this is a medication just like anything else. So you need to make sure that it matches your physician's order as well as your MAR. We're going to need an IV catheter, or what you may hear called an angiocath or an angiocatheter. These come in different sizes. During the lecture part, you'll actually hear about the different sizes and the different things that we should be looking for when we're trying to decide what size to place into a patient. For checkoff purposes, we always use a 22 gauge for our mannequin so that it doesn't cause very large holes in our mannequin. So we're going to use a 22 gauge catheter. We're going to use a saline lock. Most places now, when they are even starting primary fluids, they go ahead and put in a saline lock for the patient. So that way, if the fluids get discontinued but they still need IV access, we can just simply take off the fluids off the hub of the saline lock and still have the IV access. Again, different facilities are going to have different types of saline locks. This would be one that has a longer or an extension tubing. Then some are just the short ones that are just simply the saline lock without the tubing. So again, different places are going to have different equipment. The next thing that we're going to need is an IV start kit. Usually if you grab your IV start kit, it will include the tourniquet, the gauze, tape, some type of cleanser that you're going to use on the skin. Most places now have gone with the chlorhexidine and gone away from the alcohol and or betadine. It also has a transparent occlusive dressing. So when you're checking off, you will have to get each of those separately. And typically they're going to be laying on a table next to you or prepared for you. But that's all the equipment that you're going to need. The other thing that you're going to need is a saline syringe. And for most places now, most of them come pre-filled. And so it's already labeled saline. It comes in a package, and we'll talk more about that when I actually open it up. Other facilities, you may actually have to get a syringe and needle with the vial of the saline. So again, it depends on your facility. Do they have the pre-filled, or do you have to go ahead and grab the vial as well as the needle? Then also we're going to need non-sterile gloves. Even though this is a sterile procedure, because the equipment that we use is going to be sterile, we can just use non-sterile gloves because we're not going to be touching anything that is sterile. So we've got all of our equipment assembled. We have checked our order, so we have an order to start an IV with, let's say, normal saline at 100 milliliters per hour. So the patient does not have any IV access, so we're going to go ahead and go through all of that. So we're going to wash our hands. Then we're going to prime all the tubing that we're going to be using with normal saline or whatever solution has been ordered by the physician. Now, this can either be done at the patient's bedside, or it can be done in a medication room. Again, it's going to depend on the facility, whether they use some scanning devices or whether you're doing it with the MAR. So again, that may differ in what setting that you're in. So, prime all tubing to be used with normal saline. So, that includes two things. If you're using the saline lock, that has to be primed. And again, no matter if it is the saline lock with the extension tubing or just the saline lock, that has to be primed. So, what we're going to do is we're going to open the package. Okay. And I'm just going to set it here. Next, I'm going to open the syringe. Now, with these saline syringes, if they are brand new, what you're going to notice is that they are pressurized, and they also kind of have a small air bubble here. So the best thing to do is to pull back on the syringe, and that breaks the seal, and you'll feel it give just a little bit. So pull back. Then we're going to push, and I'm just going to set the cap up on the top of the table. We're going to push so we get the solution all the way to the hub of the needle, just nice and slow so that it gets to the very end. Okay, so we've gotten rid of the bubble. Next thing that we're going to do is we're going to attach our saline lock to our syringe. So I just kind of pull the package to the side so that I can reach the hub of the saline lock. Attach it, twist it, because it's needleless in most places now. And then we're just going to push just till we see the saline flush come out the end. Okay? I typically go ahead and leave this attached. It's up to you whether you want to take this apart, put the cap on, and set them separately. Okay? But I'm going to leave them attached. Just FYI, if we were using the one with the extension tubing, it's going to be the same process. Take it out of the package so it's new, attach our syringe to the end, flush it till we see saline coming out the end, leave it attached, and again, I usually keep it in the package so it's not rolling around on the table. So, I'm going to set that to the side. That is prepared. Alright, the next thing is, because I'm going to be starting primary fluids, I need to go ahead and prime that tubing as well. So at this point, we're actually going to switch to the other skill, which is starting the primary intravenous infusion. So if you look at the beginning, it talks about identifying your patient, confirming your order, explaining the procedure. Again, depending on if you're going to do this in the med room, you're going to wait till you get it prepared and then do that when you come into the room. If you are going to go ahead and prepare it in the room, you're going to go ahead and do that. Identify the patient with that MAR. Again, asking them their name and birth date. Again, it's a medication just like anything else. We're also going to explain the procedure. Again, if they've never had an IV before or fluids before, you may have to do a little bit more teaching. If, however, they've had several, then you may just need to remind them of what you're going to be doing. So again, we're going to wash our hands. Next thing that we're going to do is we're going to obtain the correct IV solution. And again, I'm checking it with the order, the MAR, 3 times just like we do for any other medication. So this is my order. It's 0.9% sodium chloride, which is normal saline. I'm going to go ahead and remove the covering. Once I remove the covering, I'm going to check this solution and make sure that the expiration date has not passed. I'm going to also make sure that it's clear, there's no leaks in the bag, there's no particulate matter floating around. So just making sure that it's okay for us to use. Again, in some facilities you may have to scan the medication at this time. The next thing that we're going to do is we're going to open our administration set or our primary set. So we're just going to go ahead and open it. Everything that is considered sterile is covered, okay, so we don't have to worry about that. So the very first thing, as soon as you take the tubing out of your package, go ahead and put your roller clamp down or make it tight. What you'll notice is that the roller clamp, if it's open, it feels loose and you can wiggle it with your thumb. When it gets to the tight position, it's typically rolling it down, you'll feel that it's a little bit more difficult to move around, okay? So we want to make sure as soon as we take it out of the bag, go ahead and pull that roller clamp down. In a second, when we spike it, we want to make sure that we have complete control over the roller clamp when we are allowing the fluid to prime our tubing, okay? Now, let's talk just a little bit more about priming. We talked about priming the saline lock, the extension tubing with the saline. The reason behind priming is to prevent an air embolism. If we do not put fluid through this, then the patient is going to get a percentage of air that is coming through the tubing, and that can actually cause an air embolism. So it's really important that no matter what tubing we're using, we always prime it with either normal saline or whatever's been ordered by the physician if we're talking about the primary fluids. So we've opened it up, we have pulled our roller clamp down. Sometimes you just have to kind of get it in your hand where you can reach the roller clamp. The next thing that we're going to do is we're going to get our bag of fluids and we're going to pull off the cap. And again, different bags of fluids are going to have different caps. Some of them are a little bit more difficult to pull off, but some of them are quite easy. So what I do is I have my spike that's covered in my hand close by. I'm going to pull my cap off of my bag of fluids. Then I'm going to pull the cap off my spike. Now your spike is considered sterile. So once I take the cap off, I want to make sure that it's not hitting anything that is just clean or could be contaminated. So I just pull it off. Then I take it in my other hand, while my other hand is holding the port on the bag, again holding the tubing away from it, straight in, and you're kind of twisting and pushing at the same time. And again, some of the bags that have thicker plastic are a little bit more difficult to place in. Once I do that, then I'm going to place it on a hook on my IV pole. The next thing that I'm going to do is squeeze my drip chamber. Okay, so this is the part of the tubing that is considered the drip chamber. The whole purpose of the drip chamber is so that you can see the medication drip in case you need to calculate a drop factor. So I'm going to squeeze it. Most tubings have a line that tell you how far to fill that tubing, the drip chamber. If not, then you just want to squeeze it about halfway. Again, the main purpose is so that you can see that dripping in the chamber. The next thing that I'm going to do is I'm going to let the solution go all the way until the tip of the tubing. And again, that's to get all the air out so that we prevent that air embolism. So what you're going to do is you're going to open up your roller clamp and watch that solution fill your tubing. Now, at the end of this, it has a cap on. Some tubings will not prime with the cap on, but most of them will. And again, that's going to be another sterile aspect of our tubing, so if you can, try to keep it covered. If not, take it off and then just make sure that we're holding this up. I'm over a garbage can so that my fluid can drip into there. Once I get it all the way to the end, I'm going to now close the roller clamp back so that it's tight. So I'm just inspecting my tubing, making sure there's not large gaps of air in there. Okay, here's a part that has some air, so I'm going to go ahead and open it up back up and get rid of this air that's in here. If we are priming a fluid that is an antibiotic or some other medication, we want to be careful and try not to waste very much of that because that is their dose of medication. So we try to want to get it just to the tip and where everything is filled. Okay, so at this time, if you look in your lab manual, it talks about taking that solution and the MAR to the bedside, verifying your rights. If at this time you did not have IV access, you would go ahead and start it. We're going to get back to that here in just a second. However, if you look at the next step, if you have an IV that's already in place, you're going to inspect that site for any redness or swelling. You're going to put on your clean gloves, clean the port with alcohol for 5 seconds, and flush with 1 to 5 milliliters of normal saline to assess that patency. Again, if that IV has already been started, whether it's an hour old, 24 hours old, we always want to assess patency before we hook up any type of fluid. Again, every facility is going to be different about what their policy is for the amount of saline that needs to be flushed for patency. Generally, it's 1 to 5 milliliters. Also remember that the rule is that 1 milliliter of saline needs to be pushed over 1 minute. So if we're pushing 2 milliliters of saline, that should take us 2 minutes. So at that time, we're assessing patency. If you're flushing and you feel resistance, you see some swelling around the site, we would start that IV at a different location and then hang our fluids. Alright, so what we're going to do now is we need to start the IV because our patient does not have any IV access. So I'm going to hang this on the pole. Again, everything that is sterile is covered, the cap, everything is prepared. All right, so we're going to go back to IV insertion angiocath to continue on with our skill. So we've already primed all of our tubing, our primary tubing, our saline lock that we're going to be using. Again, depending on where we're doing this, we would then introduce ourselves, identify our patient, explain the procedure. You want to raise the bed to a comfortable height. Again, you're going to be performing a skill, so you want to make sure for good body mechanics that you have the bed raised. Also, you need to turn on your overhead light. Initially, when you all start inserting IVs, you're going to rely on your sight. As you progress in your career, hopefully you are progressing with feeling the vein itself with your fingertips, but that does take some practice over time. So good lighting will help you visualize the vein in itself. So we're going to turn on the overhead light. Our bed is raised. So the next thing that we're going to do is we're going to apply the tourniquet and select our vein. So when we are starting with trying to find what site, there's a couple of things that you want to stay away from. You want to stay away from any arm that has a dialysis catheter inserted or a graft. You want to stay away from the side of a mastectomy. If this arm has a lot of swelling, maybe an abrasion, a surgical incision, anything that would harm this solution from getting into the venous system and then traveling throughout the body would keep us from going to that arm. And again, we'll talk more about that when we actually do the lecture part. Typically, when we're looking for a site, we're going to start at the hand and we're going to work our way up. Typically, I'll ask the patient which side is dominant, right or left, because we still want them to be mobile in most instances. So I try to start the IV on their non-dominant hand so that way it doesn't interfere with any mobility of their dominant hand. So we're going to say the patient's right-handed dominant, this is their left hand, so that's where I'm going to start looking. You always start distal, so you start at the hand, and hopefully we can find a site there. The reason being is that after you have to restart an IV, you always want to proceed up the arm. And so we start distal, looking, and move up the arm. So what I'm going to go ahead and do is I'm going to put on my tourniquet so that I can start determining what site I'm going to use. The tourniquet needs to be about 4 to 6 inches above your site. So I'm going to place the tourniquet about 4 to 6 inches above their hand. Now, for some people, the tourniquet is the most tricky part of this procedure. There are different ways to tie a tourniquet, okay? So I'll try to turn it so you can see. The main thing is to put it on tight enough so that the vein distends or fills with blood, but yet you don't want to put it on too tight where it's so uncomfortable for the patient that they cannot withstand that pain. So what I typically do, and again, every person is going to tie a tourniquet different. That's the beauty of nursing, is that we have so many different people and we get so many different aspects, which is great. So when you are practicing, you may ask whoever the instructor is to show you how they tie a tourniquet, and that's okay. You have to find what works for you. So what I typically do is I pull one side, put it in my fingers, I pull the other side, and then I pull it underneath the tourniquet. And so if you'll see, that gets it nice and snug. Plus, when I'm ready to take it off, I can take one hand and pull that out to get that tourniquet off. Some people do it where they just kind of push it under, and again, leave that small tab to get it off. Again, it's going to be up to you, okay? So this is going to take some practice in learning how to tie the tourniquet. So I've got my tourniquet on. The next thing that I'm going to do is I'm going to go ahead and locate my site. So I'm going to use this one that is in the hand. When you are putting an IV in, one of the things that you want to look for is a straight vein. You want to try to stay away from some valves. You want to figure this is a 22 gauge 1 inch needle. So again, you're going to have a length of tubing that's going to be about 1 inch. So it needs to be fairly straight, not curvy. You want it to be a nice size. So again, depending on your patient, they may not be able to stand or may not be able to hold some of the larger 20 gauges, 18 gauge, 16 gauge, those type. So again, you're going to have to look at that to decide what size of catheter you're going to need to place in your patient. Once I find my site, then I'm going to go ahead and take off my tourniquet. Your tourniquet does not need to stay on any more than 2 minutes at a time, because again, that is cutting off part of their circulation. So I've got some things to do before I'm going to get back to the site. So I'm going to go ahead and take that tourniquet off. At this time, I'm going to go ahead and put on some non-sterile gloves. If you put on your non-sterile gloves before you did your tourniquet, that's fine, as long as you put them on before you actually do the stick. Okay, so I'm going to go ahead and put on my gloves. I'm going to go ahead and get all of my equipment right next to me, okay? This is one of those skills that it almost seems like you need more than 2 hands. So you just have to have everything organized and prepared. So what I'm going to do is I'm going to go ahead and open my catheter. And again, the part that's sterile has a cover over it. You can either leave it in the package or set it down to the side. I'm going to get my saline lock and my flush. I'm going to go ahead and open my occlusive dressing. Again, just sit it down next to me. Get my cleansing agent. Get my gauze, tape, and with tape, what you want to do is you just want to get the tape started. Please do not take the tape, tear it off, put it in strips on your table or your bed. All that does is leave a sticky mess for that next person. So if you'll just go ahead and get it started, set it to the side, you'll be fine. Alright, so we want to make sure that we just have everything ready and that we are getting ready to start that IV. So, I've put on my gloves, I've found my site, so the next thing that I'm going to do is go ahead and prep my site with my cleansing agent. If I had an area that had a lot of hair and this was the area that I would need to start the IV in, then what you want to do is you want to clip the hair. Don't shave it, because that causes some irritation which can lead to inflammation or infection later on. So just clip the hair close to the skin. Okay? So, what you want to do is, depending on your facility, you're going to use a different cleansing agent. Most facilities now, like I said, use the chlorhexidine. Some facilities still use the alcohol, and some, even other facilities, still use the alcohol plus betadine. If you're using the alcohol plus betadine, you're going to use the alcohol first and the betadine. The most important thing when you're using betadine is to allow it to air dry, and that's the key. But most places now, due to allergies and other problems with betadine, they have switched to either just the alcohol or the chlorhexidine. So the chlorhexidine sometimes comes in a vial-like apparatus, and so it has kind of a cotton tipped end, and so what you have to do is you have to break this by squeezing it to activate. So you'll hear it crunch. Okay, and then actually if you squeeze it, you will see a drip coming down. Okay, so you just break it to activate. Then what you're going to do is you're going to clean in a circular motion at your insertion site. Do not run it all the way up the vein. You are only going to put your needle in at the distal end. So we're just going to clean, circular motion. Once we do that, then we're going to set that to the side. The other key is, again, allowing this to air dry. So we're going to allow it to air dry. If you wanted to go ahead and clean, and while it's drying you're preparing all your equipment, that is fine. That's a good use of your time. Again, sometimes in these skills you can do a little bit of switching around some of the steps, as long as the outcome is the same and as long as sterile technique is followed and you're not harming your patient. Alright, so the next thing that we're going to do, we've got all of our equipment ready. We're going to say that our site is dry, and again, remember, it's air dry. We don't wave, we definitely don't blow on it to try to get that to dry. That defeats our whole purpose of cleaning that area. So we're going to put our syringe on, our tourniquet on, 4 to 6 inches. Okay, and I'm going to try to do this from the side so that way you can see. So the next thing that I'm going to do is I'm going to take the cap off of my needle, okay? So you just pull it straight off. Now, these needles are fairly common in some of the facilities. What you're going to notice is this is an over-the-needle catheter, meaning that there's a plastic tubing that is over the needle. The needle does not stay in the patient's vein. And actually nobody uses those anymore. So when patients say they have a needle in their arm, they really don't. They have a piece of plastic tubing, okay? But that's kind of a misconception now. So what you'll notice is this catheter, the plastic tubing, slides over the needle, okay? And again, this is going to take some practice in both the lab setting, and then when you go to clinical, you could possibly have a different style of angiocath, okay? So how you want to hold this one is there are grooves on each side for your middle finger and your thumb. Your index finger, there's a tab here that you're going to hold in a backwards motion to prevent that from sliding off while you're inserting it, okay? Also, you want your bevel up. So, with my dominant hand, I'm going to hold the needle, again, to the sides. My index finger is pulling back with some backwards pressure on the tab, bevel up. My left hand, my non-dominant hand, is going to be pulling the skin taut. And again, that kind of straightens out the vein, and also so I don't have a lot of skin that's affecting that insertion. So I just take my hand underneath and pull it. If I'm up here at the arm, I can do it the same way. Just pull down on that skin to get that taut. So I'm going to go back down here to the hand, pull down the skin. You want to use about a 10 to 30 degree angle, again slightly distal to that actual site, because again this tubing is going to have to go into that vein. So about a 10 to 30 degree angle, I'm going to go in. Sometimes you'll feel kind of a slight give, or some people describe it as a pop, okay? Once I put it into the vein, then what we're hoping to see is that blood will come into the chamber. So you'll hear people say, did you get blood return? Meaning when I put this IV in, did I get blood back into the chamber? Once you get blood into that chamber, or you get blood return, then what you're going to have to do is you're going to have to advance the catheter off of the needle. This takes a little skill, okay? So, starting out, typically what's the best way is that if you will take your dominant hand, hold your catheter stable. Take your non-dominant hand at that same tab that we held into. Your dominant hand is not moving. The only hand that's moving is your non-dominant hand. So your non-dominant hand is going to take the tab and it's going to push the tubing into the vein. Nice and slow. Again, my right hand is not moving. So what you see is that now the tubing has disappeared. It's actually in the vein. So now what we're going to do is now I'm going to move my dominant hand. So it's the only one that moves. And when I pull back onto it, what's going to happen is you're going to hear a click because now that safety is engaged. So I'm going to pull back and it clicks. So that means that my needle is now protected in my safety. So at this time, what I'm going to do is I'm going to go ahead and take my tourniquet off. And again, that's why it's important to have one hand. So we have that little tab that we can just pull off. Then, very carefully, what I'm going to do is I'm going to take some gauze and put it underneath my catheter, my insertion site. The reason being is that here in just a second, I'm going to take the tubing off the actual catheter. And hopefully what's going to happen is we're going to have blood, because that means that we're in there. So, what you're going to do is, just to protect your patient's bed, go ahead and just put just a small piece of gauze underneath there. We will take that out once we're done with it. The next thing that I want to do is go ahead and I'm going to occlude my vein. Again, we want to try to limit the amount of blood that's going to come out when we take the cap off. So I put my middle finger on the vein, Then I take my index finger and I actually put it on the colored part of the catheter, okay? I reach over with my dominant hand, I pull off the cap, and that's why I like to have this attached. Then you're going to turn the clear aspect off of the catheter itself, and again, you can see that there is no needle there. It will go into the sharps. Then what we're going to do is we're going to attach our saline lock with our saline flush attached. Take off my pressure. I'm going to aspirate, and I should see blood come back into the syringe. However, just because you don't see blood does not mean that you're not into the vein. It could be up against the vein wall. So, I've pulled back. We're going to say that I've got blood into the syringe. The next thing that I'm going to do is now I'm going to flush. While I'm flushing, I'm looking at this site, making sure that there's no swelling around this area. You can just kind of slightly push with your hand as you're slowly pushing this in to assess that patency. It looks good. It's flushing very smoothly. You shouldn't have to put a lot of pressure on there, okay? So my site looks good. It's flushing smoothly. The next thing that I'm going to do is I'm going to go ahead and take just the syringe off of the saline lock, okay? And again, I won't have blood because I have the saline lock on top of the tubing. Put that down to the side or in my sharps. This gauze is going to come out, and so the next thing that you're going to do is you're going to secure your IV. Now, again, you can do this in multiple ways. Some people want to go ahead and put a piece of tape over that to secure it first. That's fine. If you want to put your occlusive dressing on there first, again, that's fine. The most important thing is that you secure it so that it doesn't come out. The last thing a patient wants is for you to start their IV, and then because you did not secure it properly, it needs to be restarted in the next couple of hours, okay? So, what you're going to do is go ahead and put your occlusive dressing on. Again, if you wanted another piece of tape, that's fine. If you're using the one that has the longer piece of tubing, the extension tubing, sometimes what I'll do is just kind of make a loop. I don't want to keep the tubing, but I'll make a loop and then tape that in there. So again, it depends on what you're using. All right, so if you look at your skill manual, we have gone through anchoring it with Tegaderm tape. You may also label it. At this time, we're going to switch back to our starting the primary fluid. So we have got the IV started. So the next thing that we're going to do, make sure that the tourniquet is turned off, we're going to put our fluids or attach our fluids. So anytime that you're attaching a tubing or a syringe to another tubing, and we call these male and female adapters, then you make sure that you're going to clean. So we're going to take our alcohol, and we're going to clean the site. Okay, so this is going to be our alcohol. We're going to clean the site, clean the end for about 30 seconds. We're going to take the cap off. Again, most of these are needleless systems, so they just go and twist. Okay. Since I have this piece of tubing, what I like to do is go ahead and maybe put another piece of tape here to hold it. So that way if the patient pulls, it pulls on the tape and not on the IV site itself. You want to go ahead and put another piece of tape, that's fine. Okay, so then I've got it secured. The next thing that I'm going to do is open my roller clamp and set my flow rate at whatever the physician has ordered. Either if it's a drop factor, I'm going to calculate that. If it is by pump, and let's say it's 100 milliliters per hour, I'm going to set my pump at 100 milliliters per hour. Then remember, with a pump, you have to set your volume to be infused. If I'm doing primary fluids, a lot of times I'll do a little bit less so that it doesn't run my tubing completely dry. So this is a 500 milliliter bag, so I may set my volume to be infused at 480 milliliters. So that way the pump will beep to let me know before that bag and tubing get completely empty. So once I've got this started, I've adjusted the flow rate. Go ahead and take off my gloves, wash my hands, and then I'm going to document. Some of the things that you need to make sure that you document is the gauge of your needle. So I started a 22 gauge. Where you started it, so I started in the top of the left hand. How many attempts times 1 attempt. Also put that you started fluid, so I started normal saline at 100 milliliters per hour per pump. Then any redness or edema at the site. And again, there shouldn't be if we're just starting it, so no redness or edema at the IV site. And then just like we end any other entry, call, light, and reach. No complaints voiced at this time. So we're going to make sure that we document, typically in the nurse's notes. Some facilities do have IV flow sheets, so that you would need to make sure that you document there.